So good morning, one and all. Either. So we all know that our glaucoma colleagues are always there to protect the optic nerve from the destruction of glaucoma. So, but sometimes the path of this protection can go haywire and threaten the vision. There comes the role of retina surgeon to protect the retina and to be the saviors. So finally, we all have a common goal to protect a precious thing of human life, the vision. So in my next few minutes, I'll be talking on how to address the posterior segment complications arising out of glaucoma surgery. It's not moving. So these are the broad headings under which I'll be covering this topic. Coming on to local anesthesia related complications, first of all, block related perforation. Risk factors include longer axial length, especially when associated with posterior cephaloma, use of longer needles, poor technique, uncooperative patient, and history of previous scleral buckling surgery. Patient will have intense pain and the globe can be hard or soft. There will be loss of red reflex. Management includes when the needle track is visualized, barrage laser can be done. When associated with vitreous hemorrhage or retinal detachment, a thorough vitrectomy has to be done. All the break areas should be identified. Fluid air exchange is done, and then laser barrage is given around all the entry and the exit sites. Finally, gas or silicone oil tamponade is used. Next complication, the retrobulbar hemorrhage. It can be arterial rapid onset type or venous slow onset type. Risk factor include use of longer needles, pre-existing vascular or bleeding disorders. The signs to recognize are hemorrhagic hemosis, tense orbit, and raised intraocular pressure. Clinically, on fundus examination, we can see presence of these choroidal mounds or choroidal folds, and classically on CT scan or ultrasound B scan, we can see the coning of the globe. Mild cases without intraocular pressure rise can be just observed. Rapid onset severe retrobulbar hemorrhage requires urgent attention and it can compromise retinal circulation. We have to deal with urgently in the form of giving intravenous mannitol, paracentesis, or performing lateral canthotomy. Coming on to hypotony related complications, first of all, decompression retinopathy. It refers to optic nerve and retinal changes secondary to an iatrogenic sudden decrease in IOP. Trabeculectomy is the most common cause. Other surgeries which can cause decompression retinopathy include tube surgeries, AC paracentesis, and laser PI in a patient who has very high IOP. Clinically, we can see the patient having multilayered retinal hemorrhages, white-centered hemorrhages, and the presence of macular edema and disc hyperemia or edema, and rarely it can be associated with choroidal detachment. Most cases resolve spontaneously and nothing needs to be done. Persistent vitreous hemorrhage requires partial vena vitrectomy. How to prevent this complication? We have to achieve a good control of IOP before surgery by giving patients preoperative mannitol. And intraoperatively, the IOP has to be reduced gradually. Coming on to next complication, the effusions. Risk factors include overfiltering or leaky blebs, use of perioperative antimetabolites, nanophthalmos, and diffuse choroidal hemangioma in the setting of Sturge-Weber syndrome. Clinically, they appear as smooth dome-shaped orange light brown peripheral mounds. IOP is almost always low, and on ultrasound B scan, they appear as convex immobile membranes with no submembrane echoes. Management includes stopping of all anti-glaucoma medications. Cycloplegics help to deepen the anterior chamber. Topical steroids are decreased in overfiltration and increased in inflammation. Systemic steroids are again used for controlling inflammation. We can opt for surgical measures to reduce overfiltration or leak. When is drainage indicated? It is indicated in cases of kissing choroidals, as you can see here, or intractable low IOP with flat anterior chamber. Serous retinal detachments can be very well managed with systemic or periocular steroids. This was one of our patients who developed extensive exudative detachment on first post-op day after OD implantation. This patient was managed with oral steroids and PST, and by 8 weeks, the exudative detachment had resolved. Coming on to suprachoroidal hemorrhage, it occurs due to rupture of posterior ciliary vessels in the suprachoroidal space due to rapid reduction in IOP. Risk factors include high preoperative IOP, severe perioperative hypotony, aphakia, high myopia, and systemic hypertension. Clinically, they appear as smooth, dome-shaped, dark brown peripheral mounds. Patients can have pain. IOP can be low or high. Ultrasound B scan shows again convex immobile membranes with submembrane dot-like echoes. Limited detachments confined to 1 or 2 quadrants can be observed. Drainage is needed in extensive suprachoroidal hemorrhage. Ideally, the drainage is done around 7 to 10 days when the blood liquefies. Serial ultrasound will help us to decide the timing of drainage. So coming on to the techniques of choroidal detachment drainage, both scleral cut down as well as trocar assisted drainage can be done. A scleral cut down is given at around 3.5 to 4 millimeter, and with the help of AC maintainer, the effusion is drained. In case of trocar assisted drainage, all of the retina surgeons are well versed with trocar technique. So in this, the AC maintainer is placed, and then around 3.5 to 4 millimeter, a trocar is placed obliquely to enter the suprachoroidal space. So as you can see here, there is an oblique entry, and then the trocar is then manipulated to drain the blood or the effusion. So coming on to vitreoretinal complications, first of it, vitreous loss. Risk factors include pre-existing PC defect or zonular weakness, aphakia, excessive local block or valsalva by the patient. Vitreous in anterior chamber can cause corneal edema, chronic uveitis, endophthalmitis, retinal tears or detachment, cystoid macular edema, and can also lead to tube blockage. So this was one of our patient who presented with vitreous in the anterior chamber and was threatening to block the tube. This patient subsequently also developed cystoid macular edema. In this patient, we went ahead with triamcinolone assisted anterior vitrectomy. So diluted triamcinolone is injected, and then anterior vitrectomy is done to clear the vitreous from the anterior chamber as well as at the tube site. Subsequently, this patient also received intravitreal triamcinolone. So this is 2 weeks post-op. We can see that pupil is nicely round. There is no vitreous at the tube site, and the cystoid macular edema had completely resolved. Coming on to rhegmatogenous retinal detachment, risk factors include pre-existing lattices, uveitis, history of trauma, vitreous loss or pars plana tube placement without adequate vitrectomy. Pars plana vitrectomy is a procedure of choice as the conjunctiva can be spared. We have to give special consideration not to fiddle with the conjunctiva too much, as it can lead to bleb leak or scarring. Pars plana tubes require special attention because silicone oil can migrate through the pars plana tubes and into subconjunctival space. The solution is that you can either ligate the tube or bring the tube into the anterior chamber through a surgical PI. This was one of our patient who developed post-penetrating keratoplasty secondary glaucoma and had a tube implantation and had a SFL as well as. So this patient, the tube was placed in the pars plana region. Subsequently, the patient developed retinal detachment with PVR changes. We went ahead with standard 3-port pars plana vitrectomy. Vitrectomy was completed and membranes were dissected. The routine steps of vitrectomy were carried out for this patient. So finally, again, the vitreous was cleared from behind the IOL. We noticed that the tube was lying behind the SF-IOL. The tube was then exteriorized, cut short, and then the tube was placed in the anterior chamber so as to avoid contact with the silicone oil. So this step is very crucial as it helps to prevent subconjunctival migration of the silicone oil. Subsequently, routine steps of the vitrectomy were carried out. Hypotonic maculopathy refers to retinal changes in the setting of decreased IOP. It is an indicator of persistently very low IOP. Clinical features include presence of subtle macular folds, disc edema, vascular tortuosity. Sometimes the disc edema can be very severe. And on OCT, we can see the presence of retinal thickening as well as choroidal folds. Management includes correction of factors leading to hypotony, oral or periocular steroids to control inflammation. Chronic irreversible hypotony, vitrectomy with membrane peeling and silicone oil injection is recommended. Coming on to the last complication, the inflammation-related complications, I will be dealing only with bleb-related infections. The incidence is around 0.1 to 1.3% after trabeculectomy. If only the bleb area is involved, it is called as blebitis. If the infection spreads to the aqueous and the vitreous, it is known as bleb-related endophthalmitis. Risk factors include perioperative use of antifibrotic agents which lead to thin avascular leaky blebs and presence of releasable sutures, inferior blebs, tube erosion or exposure. Common organisms implicated are Streptococcus, Staphylococcus and H. influenza, and they are usually highly virulent. Blebitis responds well to intensive topical and systemic antibiotics. This was one of our patients after RD implantation developed localized infection of the tube site area. So this patient was managed very well with oral antibiotics and high strength gatifloxacin, and there was complete resolution in 2 weeks. Bleb-related endophthalmitis requires aggressive treatment. Early pars plana vitrectomy is recommended. So this was one of our patient who developed bleb-related endophthalmitis, that is tube site infection. Subsequently, this patient underwent standard three-port partial vitrectomy, removal of all the membranes and core vitrectomy. Subsequently, intravitreal antibiotics were given. Then important step is to give subconjunctival antibiotics also to control the infection locally. So finally, timely intervention saves vision, and we can all be superman or woman in somebody else's life to save the vision. Thank you.
Thanks, Dr. Shreyas, for that excellent presentation. So this actually presentation reiterates the importance of working in tandem with the retinal surgeon to evade some of the complications related to